Ladies and gentlemen, good morning. Hope everybody is doing well in this abnormal situation. We are in March 2020. We are living the curfew imposed by the health authorities due to the pandemic spread of coronavirus. This is part of electronic teaching. The lecture is on pericardial disease, part of the curriculum for the fourth-year medical students, Kirkuk Medical College, but also can be for sixth-year students and even for Iraqi board students. The topic for today is diseases of the pericardium. And to remember, the heart has three layers. We were talking previously about chambers, right and left, and vessels and valves. Now we are talking about the layers of the heart. We have the endocardium, the myocardium, and the pericardium. The endocardial disease was primarily infective endocarditis. Myocardial disease was dilated cardiomyopathies and ischemic heart disease, where the vessels has been occluded and the muscle suffered ischemia or infarction. And the pericardium, which is the covering layer of the heart. And the diseases of the pericardium are actually three: acute pericarditis, pericardial effusion, and constrictive pericarditis, which is rare. Acute pericarditis is inflammation of the wall of the heart, of the pericardium itself. Pericardial effusion is accumulation of fluid inside the pericardial sac. This might lead to something called cardiac tamponade, which is very serious. And constrictive pericarditis is the fibrosis and constriction of the pericardium. This is a rare disease. Now we'll start with the first topic, which is acute pericarditis. But before that, we'll talk about the structure and function of the pericardium. It is a protective sac actually around the heart. It has two layers. The outer is the parietal layer and the inner is the visceral layers. It contains something around 50 cc fluid, the structure of which looks like lymph. It's just to lubricate the heart, but its main function actually is to limit distension of the heart and help in the hemodynamic interdependence of the ventricles. Each ventricle contracts interdependently. And it is obviously a barrier of infection, against infection. Now, the first entity is acute pericarditis. This, as the name implies, inflammation of the pericardium. As you have inflammation elsewhere in the body, for example, acute hepatitis, acute pneumonitis, acute encephalitis, etc. This is inflammation of the pericardium, where both the layers, the visceral and pericardial layers, are involved, and sometimes the inflammation extends to the myocardium, and pericarditis and myocarditis coexist. Now, what's the etiology? There are a number of causes, but sometimes the cause is not clear or elucidated. Infection is on the top, immunological reaction, trauma, neoplasm, and sometimes unexplained. But the commonest cause of infection of the pericardium is viral. So viral pericarditis is the commonest cause, and among the viruses is Coxsackie B, although the virus is not often identified. The next common thing is acute myocardial infarction. You remember there was early and late pericarditis, the so-called Dressler syndrome. Less common causes, this according to UK studies, United Kingdom. Uremia is a cause of pericarditis, it's actually rather common. Malignant disease, trauma, and connective tissue disease, bacterial infection, these are the rarest. Rheumatic fever, but tuberculosis in our country is not rare. Regarding the pathological types, it's important to know what pathologic process runs, because most of forms of pericarditis will end in pericardial effusion, and the outcome of this effusion is very important. We have four types of reactions: fibrinous, serous, hemorrhagic, and purulent, depending on the etiological factor and pathologic process. The fibrinous exudate, for example, it will cause a varying degree of adhesion. while the serous type will cause a large effusion, turbid and blue colored, with a high protein, of course. The hemorrhagic obviously is due to malignant disease, sometimes tuberculosis, malignancy of breast, bronchus and lymphoma, and we have the rarest type, which is the purulent, where it pus in the pericardium. This is usually a complication of septicemia due to direct spread from intrathoracic infection or a penetrating injury. These are the pathological types. Now, what are the clinical features of pericarditis? There's a triad of chest pain, fever, and pericardial rub. Regarding chest pain, the location actually is retrosternal, sometimes it is left-sided, and it radiates to the shoulders and the neck, so it mimics in some way the pain of myocardial infarction or ischemic pain. But there's an important differentiating point. It's aggravated by deep breathing. This is a very important question. Any patient with chest pain ask whether the pain is aggravated by deep breathing. If so, then this is a pleural or pericardial pain. And also it's aggravated by movement. The other factor, change in position, for example, from sitting to standing position. Exercise can increase the pain. This is a confusing point. And you have swallowing also increase the pain. So this is the importance to ask about aggravating factors so that we can differentiate the pain of myocardial infarction or ischemic chest pain from the pain of pericarditis. The second point being an inflammation and infection. Obviously it's associated with fever, which is low grade, but this is not necessarily present in all cases. The third, which is diagnostic once you hear it, is the friction rub. This is a sound produced by movement of the inflamed pericardium. When both pericardial layers move together, they produce a sound. And the character of this sound actually is a scratching or crunching sound, as if you put your stethoscope on, say, on the clothes of the patient. It's a high-pitched superficial one, and heard in the systole, but can hear it also in diastole. It has the quality is to and fro quality. So the features of pericarditis are chest pain, fever, and friction rub or pericardial rub. Now, what investigation to confirm pericarditis? The best investigation actually is the ECG. We can do chest X-ray, but this is usually normal, just to compare to pericardial effusion. Echocardiography again is normal unless complicated by effusion. So the diagnostic test or investigation is the ECG, and the important finding in the ECG, interestingly, is ST segment elevation. So again, this will mimic myocardial infarction, but there are important differences. The ST segment elevation is upward in concave upwards, not convex. This is concave upward, number one. The ST elevation is rather extensive, does not follow or respect the wall. In myocardial infarction, for example, you have inferior wall infarct, you have 2-3 AVF, but in pericarditis is rather extensive, not limited to a wall. Number three, there is T inversion in pericarditis, especially when there's coexisting myocarditis. But the T inversion usually occurs when the ST returns to normal, while in myocardial infarction, the T inversion can occur, even the ST is elevated. And the fourth difference, which is most important, there will be no Q wave in the ECG or in the ECG of pericarditis because there is no necrosis. And the fifth, which is a bit difficult, is the PR segment depression. And here is a more clear one for PR segment depression. So the ECG findings of pericarditis is PR segment depression, number one. Number two, ST elevation. The ST is concave and rather extensive without a Q wave. And there will be T inversion, but after the ST return to the isoelectric line. Now, what treatment? Treatment is actually easy and simple. You have pain and inflammation, obviously anti-inflammatory drugs. acetylsalicylate or aspirin in anti-inflammatory dose, not antiplatelet dose, 600 milligram 4 hourly, or the stronger anti-inflammatory indomethacin, 50 milligram by 3, and sometimes more stronger colchicine and corticosteroids. These suppress symptoms but actually do not help in acceleration of cure. The outcome, as we said, as long as the disease is viral, most commonly, recovery is the usual outcome in a matter of few days. Occasionally, it can extend to weeks. And rarely you have a recurrence, the so-called recurrent chronic relapsing pericarditis. In one condition, that's purulent pericarditis, we need antimicrobial therapy, pericardiocentesis, and sometimes surgical drainage. This is all about the first entity, which is pericarditis. Just to review simply, pericarditis is inflammation of the pericardium. The commonest cause is viral, and the pathologic process might be serous, hemorrhagic, fibrinous, or purulent. And clinically, the presentation is chest pain with fever, with pericardial rub, but the chest pain is aggravated by deep breathing, by movement, by changing position, by exercise, and by swallowing. And the pericardial rub actually is diagnostic. And the next important investigation is the ECG, where you can see ST elevation with concavity upwards, without a Q wave, and with PR depression. Treatment is, of course, bed rest and then non-steroidal anti-inflammatory drug. This is all about the first entity. The second entity is pericardial effusion. Here there is abnormal accumulation of fluid within the pericardial sac or pericardial space. What is the etiology? It is the same etiology of acute pericarditis. As we mentioned, any pericarditis can cause pericardial effusion, but here there is abnormal accumulation of the fluid. The same causes, as we said, the commonest is the viral and acute myocardial infarction, then uremia, malignant disease, and don't forget tuberculosis, because this is rather common in our country. Now, what is the clinical features of pericarditis? Of course, this depends on the size of the effusion. If the effusion is small, then the patient usually is asymptomatic. If the effusion is large, then he will feel some chest oppression or tightness. And sometimes the large effusion can compress the related structures. For example, the esophagus might be compressed and he will feel some sort of dysphagia. The signs, of course, the cardiac apex is a bit separated from the skin because of fluid, so it will be difficult to palpate the apex, or the apex beat will be impalpable. And obviously the heart sounds are separated again by a fluid, so they are quiet or soft heart sounds. And if there was a pericardial friction, then it will diminish in intensity. So the finding is apex beat, which is difficult to palpate, a quiet heart sound, and pericardial effusion that diminishes. It does not disappear in all cases, can stay, but it will diminish in intensity. Now, the outcome of pericardial effusion, which we are afraid from, and that's cardiac tamponade, I'll talk about that, depends on the hemodynamic consequences. The hemodynamic consequences of pericardial effusion depend on the rate of fluid accumulation, not the size always. It is the rate. If it is slowly accumulating up to 2 liters, the patient can tolerate without that pressure, without tamponade. But sometimes a rapid accumulation of 200 cc might result in cardiac tamponade. So it is the rate of fluid accumulation that show itself, or the hemodynamic consequences of fluid accumulation will depend on the rate. At the end, if it is quick or rapid with large amount, then it will cause severe heart failure, which is called cardiac tamponade. This is compression of the heart with a raised JVP, hypotension, pulsus, paradoxus, and oliguria. I'll talk about that in detail. And sometimes it might have a typical presentation, for example, loculated effusion, if you have previous surgery in the heart. So the main symptom is chest tightness with apical impulse that's impalpable, soft heart sounds, and diminished pericardial rub if it is present. What investigation? Echo, chest x-ray, and ECG. The most informative is the echocardiograph. Chest x-ray also informative. ECG can give a clue. You can have some other investigations like CT and MRI. Now what about the ECG in pericardial effusion, not in pericarditis? When you have effusion, especially when it is large, the voltage of the complexes will be reduced. This is the voltage calibration, and this is the voltage of the QRS. Again, you can explain by the distance from the electrode from the heart. Another finding, once the heart is moving within the fluid, which is when there is a large effusion, then you have a change in electricity. This is a normal or high QRS, and this is a low. So there is a change in electricity. This is called electrical alternance. So you have two findings when you have a large effusion: reduced voltage of the QRS and sometimes electrical alternance. Don't confuse this with pulsus, paradoxicus, or other things. The chest x-ray is very informative. Obviously, you can see this cardiomegaly with increase in the site of ciliary of the heart, which is rather smooth, and the enlarged effusion, it will be a globular or pear-shaped. Of course, the definitive diagnosis will come by echocardiography. This ultrasound of the heart. This is a normal heart. These are the atria and these are the ventricles, and this is interventricular septum, and this is interatrial septum, and these are the tricuspid and mitral valves. This is the chest wall. In between these two, you can find clearly this black area, which is the fluid around the heart. Although you can see the position of the chambers a bit not looking normal to you. And this is, let us say, inverted heart shadow. These are the ventricles, and these are the atria. This is interventricular septum, interatrial septum, and around the heart you will see this black area, which is the reflection, sound reflection of the fluid. So by echo, sometimes you might do a CT or MRI. This is not necessary in all cases. This is effusion anyway. Now, management of pericardial effusion. Of course, the most important thing is pericardial aspiration. The indications are for diagnostic purpose. You aspirate some amount of the fluid and send for the lab, and the other for treatment if we have a large effusion that causes hemodynamic compromise or cardiac tamponade. We can do this and accomplish by introducing a needle in the subxiphoid area or in the apical area. The direction of the needle to the left shoulder, although this is not a proper picture, but this is not without complication, of course. Sometimes you injure an epicardial artery, coronary artery, and sometimes arrhythmia can occur, bleeding or exacerbation of tamponade, and sometimes further bleeding if the tamponade was due to aortic, for example, dissection. But this is a life-saving procedure in tamponade. What is tamponade? The thing that we are afraid from. This is actually acute heart failure due to compression of the heart by a large or rapidly developing effusion. When you have compression of the heart cannot fill. You know there is diastole and systole. When the heart is compressed from without, then the heart cannot fill and even cannot give a good output. The etiology mostly is a complication of pericarditis, and you know the cause of pericarditis. It can be complication of malignancy, trauma to the chest, or rupture of the free wall of the heart. So the commonest is complication of pericarditis. Now, what are the clinical features of pericardial tamponade? We have a triad. Don't forget these triad. tachycardia, and hypotension, and then raised jugular venous pressure. Mostly in a busy outpatient or casualty, this point is neglected. Any patient with tachycardia and hypotension, you think, or hypotensive patient, usually develop tachycardia because of sympathetic stimulation. And mostly when we see such a patient in the casualty, we think that there is hypovolemia, and usually we start fluid. This is actually contraindicated. Always, whenever you have, the advice is like that. Whenever you have a hypotensive patient with tachycardia, immediately look to the JVP. If the JVP is low or absent, then this is fluid loss or volume loss. If the JVP is raised, then the first differential diagnosis will be cardiac tamponade. Of course, there are other right ventricular failure, etc. So the clinical features of pericardial tamponade are the following: the symptoms and signs. The patient generally looks unwell, he's tired, he will be dyspneic, and sometimes he will collapse. Then, on examining the pulse, you have tachycardia and possibly weak volume, blood pressure will be low, and then immediately the sequence of cardiac examination, as you know, general, well or not, pulse, blood pressure, JVP, and then precordial examination, not pericardial, precordial examination. So he will look unwell and sometimes dyspneic. The pulse is tachycardia, probably with a weak volume. Blood pressure will be low, and the JVP will be raised. Obviously, the apex beat is difficult to palpate, and you have a soft heart sound with early third heart sound. And these are details, it's not important for all of you. And you have pulsus paradoxus. This is very, very important. When you check the blood pressure, there will be a large fall in systolic blood pressure during inspiration, usually 10 to 20, but this is a large fall of blood pressure. The name is pulsus paradoxus because you can check it in the pulse as well, but it is usually by blood pressure. The other is Kussmaul sign. There is normally the JVP during inspiration drop. Here there is paradoxical rise in JVP. So during inspiration you have a fall in blood pressure and a rise in JVP. Anyway, the important thing is that the patient looks unwell with tachycardia, hypotension, and gross elevation of the JVP. Obviously, when you put your stethoscope on the apex of the heart, you can hear the heart sounds properly. Now, how to investigate a case of pericardial tamponade? Obviously, echocardiography is very important. It is confirming the diagnosis, and you can identify where to have the aspiration, whether the apex or the xiphoid area. The ECG will show the features of underlying disease, and as I told you again, whether there's pericarditis or acute MI. In large pericardial effusion, the EC complex will be small, and as I said, there is electrical alternance. The chest X-ray will show a globular heart. Much looks like the features of pericardial effusion, but here it is large, and the patient usually is tired. Now, what is the treatment? Obviously, it's a medical emergency. There should be prompt aspiration. Once we confirm the diagnosis that we have pericardiocentesis, and actually once we aspirate the fluid, even small amounts, then there will be dramatic improvement. So this is a medical emergency. Once you see or diagnose the case, immediate aspiration, and then there will be dramatic improvement, and in some cases we need surgical drainage or tube. So to summarize this important entity, cardiac tamponade actually is pericardial effusion, which is a bit large or rapidly accumulating. The etiology is the same as acute pericarditis, but sometimes malignant disease, trauma, etc. The clinical features is a patient who looks unwell, dyspneic, with tachycardia, with hypotension, and a raised JVP, and distant heart sounds, pulsus paradoxus, and Kussmaul sign. Echo is confirmative, and the treatment of choice is actually aspiration of the fluid, pericardiocentesis. Now, one topic which deserves some talk is tuberculous pericarditis. You know, tuberculosis is common in our country. Commonly, we have pulmonary tuberculosis, but sometimes you have extrapulmonary tuberculosis like meningeal TB, joint TB, etc. So one of the complications of pulmonary tuberculosis is pericardial tuberculosis, and sometimes it might be the first manifestation, although in other countries like Africa, it might be a feature of AIDS. Now, the interesting thing why we stress this point is the clinical features. The patient will feel chronic malaise, weight loss, and low-grade fever. You notice that there is nothing pertaining to the chest or to the heart. Just you have a patient with chronic malaise, weight loss, and low-grade fever. And when you take an X-ray, you will see a large heart and sometimes calcification and even associated pleural. This is a very serious disease because any tuberculous pericarditis, the outcome will be either pericardial effusion or constriction. The effusion might culminate in tamponade, or the pericardium might become thick and unyielding and end in pericardial constriction. So both entities can arise from tuberculous pericarditis: pericardial effusion and tamponade, and pericardial constriction. Of course, the diagnosis by aspirating the fluid and direct examination and culture of tubercle bacilli, and treatment involves anti-TB, which you know, rifampicin, INH, ethambutol, and pyrazinamide, and then a 3-month course of prednisolone, initially 6 mg and then repeated tapering. Usually serosal TB needs steroid to prevent adhesion. The last entity, which is rare, so the rare diseases we don't concentrate more, is chronic constrictive pericarditis. Here there is progressive thickening and fibrosis and calcification even in the pericardium. Thickening, this is the pericardium, thickening, fibrosis, and even calcification. So the heart looks like it is encased in a solid shell. Obviously it cannot fill. When fluid comes, the superior vena cava and inferior vena cava bring blood to the right ventricle, then this is encased in a shell, it cannot fill properly. So it cannot give a proper output, and in addition, the calcification might extend to the myocardium, and you have even impaired myocardial contraction. Etiology, obviously, tuberculous pericarditis on the top. Hemopericardium, when you have blood in the pericardium that ends in calcification. Occasionally viral pericarditis and rheumatoid arthritis can be a cause, and purulent pericarditis. For us, tuberculous pericarditis and hemopericardium are the top two. Obviously, the clinical features are mainly due to systemic venous congestion. Signs and symptoms of systemic venous congestion, because the superior and inferior vena cava find some difficulty to fill the heart. The patient will have fatigue. The pulse will be rapid and low volume, and sometimes atrial fibrillation, which is common. The obvious thing is a raised JVP. Again, the JVP which rises during inspiration. The apex can be palpable, but the heart sound, you will have early third heart sound, the so-called pericardial knock. Then the congestion of the systemic veins, we have inferior vena caval congestion, hepatomegaly, which is a huge, and ascites, which is dramatic, and then peripheral edema. So peripheral edema, hepatomegaly, ascites, and raised JVP, these are the main features of constrictive pericarditis. Again, pulsus paradoxus is a finding. But one important thing, if you notice you have raised JVP, hepatomegaly, edema, this looks like heart failure, but there is no breathlessness. Usually there is no breathlessness. So whenever we have features of right-sided heart failure without breathlessness, or the chest X-ray is normal, then think of this disease. When the chest X-ray usually show a normal and small heart, and we don't have a dyspnea, then the differential diagnosis will be constrictive pericarditis. Obviously, the investigations will be, again, chest X-ray that show calcification, echo is diagnostic. Occasionally, we might need CT and MRI. There is one differential diagnosis which is difficult actually, is restrictive cardiomyopathy. This is the chest x-ray. You see pericardial calcification in the lateral view, and here also it's some calcification, and again this is the calcification. The echocardiography show increased echogenicity, and even the calcification can sometimes seen. Of course, CT and MRI sometimes are helpful, and the treatment is surgical resection of the diseased pericardium that sometimes have a dramatic improvement, but this is not without complications. It has a high morbidity, and the benefit, even whether although dramatic, is only 50% or less. So to summarize this lecture, we have three entities or three diseases of the pericardium. The first is pericarditis, just inflammation of the pericardium, where the patient is having chest pain that's aggravated by deep breathing and movement, low-grade fever and friction pericardial rub, and the ECG will show ST elevation and PR depression, and treatment is non-steroidal. This might be complicated by pericardial effusion, these features of which depend on the size. If it is small, it will be asymptomatic. If it is large, it will cause chest tightness and the apex beat that's difficult to palpate with soft, hard sounds. The best diagnosis is actually by echo, although the chest x-ray and ECG are helpful, and the treatment is aspiration. The most serious complication of pericardial effusion is cardiac tamponade. That's accumulation of a large amount of fluid around the heart that causes some sort of heart failure. The clinical diagnosis is by finding a hypotensive patient with tachycardia and raised AVP. Obviously, the echo is very diagnostic, and the management is aspiration. The other thing, tuberculous pericarditis, is one of the inflammatory processes, but interestingly, it has no feature pertaining to the heart or the lung, present with chronic malaise, weight loss, and low-grade fever, and diagnosed again by aspiration and treatment NTTB with steroid. The last was constrictive pericarditis. It can be an outcome of tuberculous pericarditis, and features are due to systemic venous congestion, and treatment is surgery. Thank you very much for your listening.